My name is Rachel Stevenson. I'm the Events and Social Manager here at Identity Automation, and I'll be the moderator for today's discussion. So today, our expert panelist is James Carpenter, Director of Information Technology and Security at Texas Scottish Rite Hospital for Children. In today's discussion, response to COVID-19, an open forum with Texas Scottish Rite Hospital for Children, we're facilitating an interactive environment for IT personnel in the healthcare industry to come together with expert panelists to exchange questions and ideas on how to manage the challenges healthcare is facing in light of COVID-19.
Thank you. Well, brief is a good way to say it. I've been at Scottish Rite for 4 years now, getting on my 5th year. I guess in the life cycle of a security officer, that might be long, but been there 4 years. My previous role was at a much larger health system for 17 years, I think. So this is my second go. Been in cybersecurity and healthcare IT infrastructure pretty much all of my career. Started in help desk, went up to desktop servers, networking, any other area you can imagine, databases, programming. And one fateful day, I decided to become a technology officer and a security officer. And here I am today at Scottish Rite Hospital for Children. It's been a blessing, and it's a great job. We have a wonderful mission at Scottish Rite, giving children their childhood back. And so every day is a cool day because I'm doing what I love, and the mission that I support is greater than myself, and it's a wonderful mission. Well, you know, this is a discussion about COVID and kind of an impact. And so the overview you see on your screen is kind of a rough sketch of a document I put together. But I want to talk about COVID in terms of how it impacted Scottish Rite kind of before, during, and well, we're kind of during now, but we're kind of getting towards a return, if you will, to normal life, as normal as it can be. So before COVID, we were kind of a, a slow, hospital sort of in terms of change. When things change, we wanted to talk about it, meet about it, get everybody's approval and things like that. And that's not a bad thing. We're very family-oriented culture, and we want to make sure that everybody's okay with something before change takes place. And so that's kind of where we were, and we were operating according to a plan in IT. We're augmenting our disaster recovery. We're kind of dabbling in some things, and then here comes COVID, right? So there's 1,000 people on site that literally within 5 days, everybody needs to disperse and go home, and that was a huge disruptor because the technologies were pretty centric to folks that joined IT or joined the workforce, or joined Scottish Rite in 1995. The average tenure at Scottish Rite is 26 years, I think. So a lot of folks still want the hard phone on the desk, and the big computer on the floor with your keyboard here. And now the world's changed where everything's mobile and you have to leave all that behind. So we had a rapid transformation take place that was kind of a shock to the culture system. Now, fortunately, we had a lot of good things going on under the hood in IT that made that transition very rapid and very possible. So it was really more a matter of getting people to the new world quickly. And so I'll talk more about that, but where we are now is essentially everybody is very comfortable where they are. I called my boss the other day and asked him, what's going on with the phones? I think my phone's broken. Nobody's calling my phone. Well, that's because they're all Teams chatting and video chatting and sharing documents. I mean, these are people that would, require the phone or print out a memo and carry it to you. And here we are, just saying, send it to me in chat. So it's been a really awesome change to watch take place. And someone asked me, as the initial impact of COVID was taking place, and we were starting to get the workforce transitioned to a more mobile mindset, someone asked me, how are things going? They asked in a kind of somber tone, how are things going? Because, it's really bad out there. And I said, man, I thought about it. One of the few times I've thought about something before I said it. I said, things are going fantastic, and they're like, what are you talking about? Well, and I think what I meant by that was the organization was able to make it to the other side, and the things that I've been doing under the hood, which I'll share a plan here in a moment, open it up for chat on that. The things that I've been doing have come to fruition. So the things that I've been working on that I love to do, strategy, operating to a kind of guiding North Star and always incrementally improving the environment, were coming to fruition a lot quicker. And so, there's value in that. And the organization, in some ways, viewed IT as the savior of the day, because we're enabling clinical visits to continue to take place through telemedicine. We're able to keep the communication interdepartmentally via Teams. We're a very rapid rollout with Teams. And for some of the more complex applications we have, we were able to deploy Meraki's, the Cisco Meraki solution. So I'll stop there because there's a lot more to say, and ask if there's any questions, and there's some topics on the overview here that we might want to get into. So we talked about the pre, the during, and kind of where we are now. And there was a couple of things, who was it that said begin with the end in mind? There was a management leader there that said begin with the end in mind. So I feel like the same for this session. The end for me is that there's some takeaways from this, what we're going to talk about. And I think at all times, regardless of COVID or anything else, you should always be laying a foundation for something, or, working on strengthening your foundations. And I will show you a timeline here in a sec that kind of outlines what I'm talking about. And you should always be testing new things. I call it a skunk works. Have something in the works, new tech that you want to try out, to see ways of applying new and better ways of doing things. And then also understand your I call it the free marketing department. Every organization has the squeaky wheels, or the people that will be critical of the things that you do in IT. And those are the perfect people to go to and say, I have found the perfect solution for you, because they will say, well, not so fast, I'm gonna analyze that for you and let you know. And the last thing I'll say is, a good takeaway is make sure that your work is aligned to a higher calling, something that you're really into and that you can get behind, because then the work that you do really creates a passion in you. And then your staff as well. Your staff feel that, and they have something to latch on to for creating their own kind of passion. And I'll stop there real quick, see if there's any hands raised. If not, I do want to share a screen that talks about kind of an evolution, not a revolution. So I'm going to practice this share screen thing. So if I mess this up and totally disconnect myself, I promise I'll come back as fast as possible. So let's see, make presenter. That makes me a presenter, right? Okay. And then I'm going to share my screen. And I think this is a pretty insightful shared window to kind of go over. Now it's a little fuzzy. I have one of those gaming monitors. This is my gaming headset. I love playing video games, so I have to get the biggest monitor, best headset ever. Got to hear those people sneaking up behind you. So it may show kind of teeny on your screen, but there's a timeline that started in 2018 and goes all the way through to present. And when I arrived at the hospital in, a long time ago, we were still running Novell. If anybody remembers Novell, GroupWise, and some really old stuff, mainframe type stuff. We had single point of failure type connections to AT&T and Verizon, just all kinds of problems. So I literally spent my day chasing problems. And now COVID happened down here towards the end. So when I say things are going fantastic, when I was talking that conversation, I had already gone through and built in a resilient disaster recovery network, taken out all the Novell, replaced it with AD, upgraded the infrastructure, moved things over to the cloud, kind of in line with an architectural roadmap that looks something like this. Similar to the previous timeline, we have a timeline at the bottom, but we have an evolution of things. So when we began, our architecture was pretty rough, and we got better the next year, and we evolved ultimately to here, where you have most things dual connected, multiple connections to Azure, Amazon, and all of our facilities riding multi-gig rings, so that if the internet goes down, Scottish Rite doesn't go down. So that really set a stage pre-COVID. The only thing we had to do going into COVID was get people onboarded onto the cloud in a full way, meaning they had to install Teams on their devices. First, we had to figure out what we were going to use. So we decided to use Teams because Teams was in our skunk works already. So the IT team got a chance to go ahead and deploy what they, were already comfortable with. So, now that you kind of seen the timeline and understand what I mean about evolution, not revolution, building the foundation, that made COVID life a lot easier, the transition into COVID life, because the platform was set for getting people home and there was an application for them to use. There was a means of communication. Also in the skunk works was the Meraki devices. We only had, I think, like 20 of those things available, and we had 700 people to send home. So we used a combination of Citrix and Meraki. And the Meraki technologies, if you're familiar with them, kind of bring your home as if they were in the office. So every connection into the Meraki device is just as if you're in your hospital. So that all worked out pretty well, and now folks are pretty comfortable with it. And there's lots of other things to talk about on this list, and I will jump into them if nobody raises their hand and makes me zip it. So the financial impacts were interesting to the hospital when we went into COVID. We went into COVID with probably 250 to 300 ambulatory visits per day. That's people coming to the hospital to have an examination or whatever and then leave the same day. And then surgical, I think we had 7,000 to 9,000 minutes of surgery per week. So that, of course, after surgery, you have to go recover, and so that results in inpatient time. So there was lots of patients on the floor in recovery rooms. So when COVID took place, those dropped to near zero while we figured out what was going on. So the way we approached COVID was to call all these thousands of people and reschedule their appointments for a later time that the public or all the information was saying COVID should be mostly peaked by then, and so you can start ramping your services back up. So that was around June, but we ended up calling those thousands of people again and rescheduling for even farther out. Meanwhile, we scrambled to put telemedicine in. And all that means the reduction of patients coming through the hospital, reduction of revenue. And so fortunately, the hospital is very, very well positioned in terms of finances and able to sustain through this crisis. And I say that not in a prideful way. I say that to say that, we've got really good leadership at our board and our leadership team in how they manage the finances and the future of the hospital, really thinking, 100 years out kind of stuff. So in that way, we're able to make a commitment to the employees, which this is huge, I think. The promise to the employees that we will pay each and every one of you employees, even hourly employees, through the rest of the year, through September, which is our fiscal year. And I imagine if we go on beyond that, my gut tells me they'll probably keep doing that as well. And that has a huge motivational impact to staff. I mean, there's been a lot of letters from staff to board members and leadership thanking them for their commitment to their families. And of course, that in turn creates a commitment back to the hospital to do everything we can to get the hospital back in the game, full force like we were before. And to that point, full force like we were before, even our top docs and our top leaders are recognizing that full force isn't applied the same way anymore. It doesn't always have to be physical visits. A lot of visits are now turning into telemedicine visits. So I talked about volumes before, 250 to 300 visits per day. And now we're up to, I think, 44 visits physically plus 16 visits last Friday. So, we're getting there. The volumes are starting to ramp up. And a lot of that's not necessarily a push by the hospital. You see pushes in the news of organizations pushing to get back in business, trying to force something. We're calling patients and having a discussion with them. And if the patient feels comfortable with a telemedicine visit, we'll do a telemedicine visit. They don't have to drive in from, San Angelo or Waco. They can stay at home. We'll take care of them just like we would if they came on site. So the staff uncertainty and the motivation was well taken care of, I believe. And a lot of team role changes. I'll pause before I get into team role changes to see if there's any questions out there or raised hands.
It
All
doesn't
right.
appear to have any. Nope.
Well, I must be knocking this thing out of the park. I
You're
tell you,
killing it. Yep.
I'm just killing this thing. Well, team role changes were interesting. So I see it on the going into COVID side, and I see it on the leaving COVID side. So the going into COVID side was what job roles need to change to keep this place running. And for IT in particular, I'll call out one, which was desktop support. I mean, if nobody's at the hospital, why do we need desktop support, right? So we transitioned all of the desktop support into help desk / desktop support, and we rotated people in essentially one at a time. So whereas you might have 7 people on site, you might have only one person on site, and they take care of the physical things. Um, and that was important to rotate the one on site for a couple of reasons. One, not all things can be done virtually, but 2, it limits the amount of PPE gear and social interaction and the need to take temperatures and all of the things that COVID has brought to organizations in this crisis. So instead of having that impact a lot of people, it only impacts a few people. And so that was one role change that took place, and that was a very synergistic, to use a word of the day, approach, because at the same time we needed offsite people, we also needed labor hours associated with typing up really simple and easy to use instructions for those folks I was talking about that joined the hospital in 1995 to understand how to use modern technologies. So some of them were set aside to be on the other ends of Teams test calls, where people can call in and test and have a conversation about how it's working and tweak it. Don't put 2 microphones next to each other, that kind of stuff. And then some of the team that were good at documentation and kind of graphics could put together really easy to use brochures to give to staff. And then the technology teams, these are the network team, the server team, and to some extent the telecom team. Those teams were transitioned more into a support role and off of a project role. So there was lots of projects going on that we stopped to shift into get the organization rolling again. And now that the organization's rolling again, you see us starting to pick back up on our projects, because collectively, I think the organizational statement would be, we've got this, we've got this. And if you were to look at Scottish Rite's Facebook page, there is some just great videos out there that shows that, we're still staying connected to the public and the community. And there's a particular one, I think, on the 16th of last month by a nurse. Andrea is her first name. You got to go watch that video. I don't want to talk about it too much more because I'll just start crying, because I'm a softie like that. But I love those Scottish Rite videos, and I think you will too. And it's not a sad story. It's just a joy kind of story. It's like, wow, what a great heart, and so that's kind of some of the things we're doing during the crisis. And there was somebody that asked me about, what about the disconnectedness factor? We do need to get together to stay connected, and definitely Scottish Rite, because we're a connected family. And so one thing, it's an interesting byproduct, I never thought I would see it, is that I feel like in that video where you'll see on the Facebook page of that nurse, there is actually, you get to know people a lot better because you have one-on-one interactions in the webcam, whereas before you might just be sending off an email. And it really does change the dynamic of your relationships. And I feel like I know people more now than I knew them before the crisis. And so when we get together, there's that kind of, yeah, gotcha, kind of thing going on. So it really helps. And I'll say one more thing before I pause again, and that's the new dialer service for nurse calls. This is something that emerged as well. And that is, with all of these people going home, the office phones are left on the desk in forward mode to people's cell phone. So we found out right away that not everybody leaves a professional message on their personal cell phone. So we had to address that, change some telecom rules, and come up with some policies to tell people you need to check your office voicemail, but also consider updating your personal voicemail. But also this interesting challenge occurred where rescheduling has to occur, so the nurses have to call out to patients. and reschedule their appointment. Well, if they call out on their personal cell phone, the patient's getting someone's personal cell phone, and they don't want that. So came up with some interesting solutions. The Meraki really helped with that because that allowed us to bring the actual physical office phone into someone's house, hook it up to the Meraki, and it worked just like you're in the office. And that might seem like a semi-archaic solution to the problem, but it is a good solution for the problem because nurse schedules are typically in a queue, and they're managed by a telecom group called an ACD, distribution group. And so you have to maintain all that back-end technology and still work. And another innovation, and it's probably not an innovation to a lot of folks out there, but is the use of the Microsoft Teams. We rapidly moved Microsoft Teams into the dialer aspect for people that needed it, so you can use your Teams to place an outbound call. Now we're in the Skunk Works now is, we're purchasing various Microsoft compatible phones, and you just log into the phone with Teams. And so that has the potential of replacing or augmenting the existing phone system. So a byproduct of this all could be that the phone system actually gets stronger, and we have a stronger resilience for our DR plans, our BCP plan, as I see there, business impact analysis. So the continuous improvement, so there's continuous improvement in all this. So I'll stop right there because I promised to stop after talking about role changes, but I just kept going.
We do have a question that's come in. So I know you were touching on your nurses. So any staff augmentations that you all had to make, have you all had to, bring any staff in, send any staff out? How is that going?
Well, most staff went out, including the nurses. Nurses on site correlate directly to how many patients are being seen. So when the patients drop, the nurses drop. But the nurses don't just go home and do nothing. We did see nurses go home and start doing other things like getting on the phones and calling. So their role changed too, to do rescheduling activities. And some nurses were redeployed to the various entry points of the hospital to help with temperature scans. There's some educational material that's out there that we're working on. There's research. We have a research study that we've published, I think, out on our website that I think it's open to the whole world you could take, but the nurses are participating there too. So there's no staff augs that have taken place that I'm aware of. There should have been if we were similar to other places, staff reductions, but we did not do that. Made a commitment to our employees, so we didn't choose to do that option. So I think staffing's doing fantastic right now.
That's great. And it sounds like your staff morale is high as well.
Oh yeah. I mean, they are in the mode of like, can we keep this going forever? I mean, we like this. So that's a challenge too. So I think when we return, it's going to be a combination of the two worlds, the remote work plus the on-site. Before this thing, always on-site 5 days a week. So that changed really quickly. Yeah, so we talked about shifting employees off-site in 1 week. That was a really rapid change. And I tell you, the culture change associated with that was a real shock factor. There's some people, that are just not going to make the change. And so, what we kind of did from an approach perspective is take care of the 90% and then work back into ways that we can accommodate everybody working from home. And, this is just a technology adoption thing. Sometimes you get so used to doing things the way you do it, you really don't want to do it any other way. And it takes time to overcome those things. So that's been a very teeny challenge. I think for the most part, the entire organization has just really shifted very well. Talk about the business continuity plan really quickly. I don't think I have the document available, so if I did, I would share the updated business continuity plan document that I've been working on. But essentially, I dusted off the old business continuity plan and prioritized the various applications, used the COVID situation as an opportunity to assess whether what we say in our business continuity plan is true anymore. So what are our critical applications? Are they still the critical application, and are they still ranked in that criticality order? So that was one thing we checked. And then the other thing we checked was the infrastructure. Are all the critical services accounted for? So we did have an outage while we were working remotely that I had to make an addition to, and that was DNS services. So when we did have an internet connection go down, or a network connection go down, that tied back to our DNS servers, which meant that people couldn't, navigate the internet because they couldn't resolve the name. So that got added to the list, prioritized pretty highly. And then the types of incidents that create an emergency that would trigger business continuity got updated as well. So we had the typical fire hazard, water hazard, and all that stuff. Pandemic was on there, but it was like, this will never happen. So there was some light wording around it. Well, now we beefed up the wording totally, in that section, and there's all kinds of new information to put under what you do in the event of a pandemic. And centric to the what you do, the theme is generally make yourself mobile, just be able to distribute and achieve the same level of IT services you did when you were all in that same facility. So really the heart of the disaster recovery and business continuity planning now is all centric to distributed workforce, two of everything, so that if something breaks, another thing can pick it up, and cloud, but secure cloud. In all of this, we haven't really talked about security much, and security has been a bulk of my work doing this. I feel like we can talk about that for a long time, so I'll introduce it like this. When you leave the hospital, where the prevalence of reminders of HIPAA and all these things are amongst you, and you're at home and you need to share information, the propensity to share information containing protected health information or other sensitive information is high, because you want to get your job done. And so you're doing things you don't normally do. So we've had to issue a lot of guidance around protecting patient information through public mediums, particularly which webinar program are you using? Are you going to use Zoom? Are you going to use WebNow or whatever, Teams? So we have to define that we are using Teams. We have a business associate agreement with Microsoft. That's the place if you're going to do it. But IT is going to be on the watch. I mean, just this morning, I attended our daily operational huddle to kind of get an overview of what's going on in the hospital. And, there was a discussion about sharing the COVID-19 testing schedule. This is a schedule where patients drive their car into the hospital, get COVID tested prior to their surgery, and then they drive off. Well, we have to be there with a laptop or a tablet to verify the identity of the person in the car that has date of birth type, medical record number information. So question is, in the operational huddle, James brings up, how are we protecting that? We need to continue protecting information even in the middle of a crisis. So cybersecurity is super important, and I'm sure everybody has been seeing all this phishing stuff related to COVID, and all kinds of phishing scams that are going on out there. Masks, hey, we can give you some free masks or stuff like that. Just click here. So we have a daily, I would say maybe a near daily COVID update that comes out from top brass, if you will, that talks about our current situation at the hospital. What are our plans? What do the numbers look like? And then nestled in there is the cybersecurity reminders about don't click any links related to COVID, current scams out there. And the current scams list that we get typically come from the Secret Service or FBI or the North Texas Crime Commission. They send out these bulletins, and I basically read the bulletin, get the gist of it, and repackage it up in Scottish Rite Ease language. So there's just a lot going on operationally in cybersecurity.
We do have a question for you. So obviously Scottish Rite is located in the Dallas-Fort Worth area of Texas. Identity Automation, we're in Houston, Texas, so we know Texas is kind of opening up. How are you all seeing your caseload level in relation to the opening of the state of Texas, and how are you all handling that?
We are opening with Texas, but using county and city guidelines. So there's a great video of some of our doctors out there. I think it's on our Facebook page talking about this, but essentially the word that we use is nimble. So we are slowly creeping up our visits sprinkling in telemedicine to bring the numbers back up. And we're really letting patients decide, how they want to do it. We call them and say, and by the way, the patients are clamoring to come back. They love Scottish Rite and they want to come back, and we love them and we want them to come back. So when we call them, this is a new thing to them. When we call them, it's not like in the past where we've called them and said, come on back, and they know how to get here. It's like, come on back, but we have an option for you if you have an iPad or a mobile device. And a lot of them are taking us up on that. So the word is nimble, and nimble means we receive daily reports from the city of Dallas and Dallas County. I think the city of Dallas has an innovation team, and I think that's where we're getting the reports from, I believe. But it shows the daily, new cases, ICU beds availability of area hospitals, and Scottish Rite's part of that area hospital mix. And so we're keeping a real close eye on that. And if that gets to a point where it looks like it's unwieldy or unsafe, then we'll back off on the visits. Of course, that means calling people back and rescheduling. But the pace at which we're growing is really safe, I think, because we're talking about, the previous week's numbers being like 36 and the next week number being 44. And the all-time highs are up in the 300s. So, I mean, we are still in the easy to fix it zone. If something comes up, we could fix it on the fly. So that was a good question, and I think that is going to continue for some time based on what I'm seeing. Well, I've got another document over here that you guys don't see with some other things I could potentially talk about. Talk about team excitement, if you want to talk about that. That seems like an exciting topic. So, COVID, really any kind of crisis like COVID, you can approach it from two methods. You can approach it from a fearful angle, and a fearful angle might be where leadership might say, man, I don't know what's going on out there, guys. I wouldn't come in if I were you, but there's no leadership aspect telling folks what to do there or giving them any sense of hope. So you can approach it from that way, or you can approach it with a plan and with confidence. And we are on the other side, the plan and have a plan and have confidence side, meaning, we as leaders, and this is pretty much all directors and above at the hospital, we operate from the plan and we instill confidence, in particular to IT. I can only really speak about IT and how I've been approaching it. I'm a Christian person, so everything I believe is biblically based. I kind of believe that what you think about, what you focus on, becomes, the situation. So, you need to approach things in a positive positive confession kind of way. And so we're going to work this thing out where there is a light on the other side of the tunnel. It's going to be fantastic. But getting the team excited about this, that's the beginning, is to say, we are going to make it through. So now the question is how, and so the question is, we're going to do it together, so you don't want to do things to people, you want to do things with people. And so the good news, I showed the plan earlier about how we evolved over time. And when you have a crisis, the organization looks to people for answers. And I mean, everybody's looking around for answers, right? So if you're the guy that can come out with a plan and the answers, you're in a really great spot, and so we had the plan, we had the answers, but how does that translate into team excitement? Well, the team are the ones that basically created the plan through their works in the previous 2 years. So, when I get on conference calls with the teams, I say, look, guys, you guys have designed the answer to this problem. I mean, you're 90% there. All we have to do is tell people how to use this stuff and buy some more licenses, and we're golden. I mean, you guys are going to be legends, And so, I mean, they're super excited because I've got people, as an example, that are making videos to help other people where they just wouldn't have done that before because they just didn't have the time or whatever. But now I've got IT staff who you wouldn't think would normally do such a role, creating videos to train everybody in the hospital how to use Teams or how to use Microsoft Office tips and tricks videos. And it's the work of their hands, and they are super excited about that. And so what's great about that too is they see in the leadership above them that the leadership above them is okay with them testing the waters of the unknown and coming up with cool design solutions for things, because they will support them. Leadership will support them and actually won't, take credit for their work and then say, oh, those guys down there don't do anything, We actually give them credit, and it's an honor to give them credit, because, it's just a circle kind of thing. If we take care of our staff, they'll take care of us, but more importantly, they'll take care of the hospital and all the patients and the families we serve. And so, they're just super excited. And of course, doesn't hurt that the organization says, we'll make sure you and your family are taken care of for the rest of the year, and probably farther than that if it came down to it. So super excited staff.
Let's see if we have any more questions roll in. Okay, here, let's talk vendor relations. How are you all working with your vendors as the demand for healthcare vendors are at an all-time high?
Well, they sure are. I'll tell you one particular vendor category that is at an all-time high, and that is thermal imaging cameras. I'm telling you, I've never seen so many thermal imaging camera emails in my life, but a lot of vendors are calling to see how they can help, and that's a great thing. It's not just calling to say, how can I help? And oh, by the way, we got this special deal going on licenses right now. It's more like, how can we help? And so we've had just a ton of local vendors. We do some local stuff, for example, iPad, tablet repair for broken screens, batteries, and things like that. But we've had a lot of vendors come in and actually provide lunch for the nurses, which is super cool. I'll just go ahead and give some mad props to Raising Cane's out there. Raising Cane's, if you see this video, you guys rock. I don't know what's in the special sauce, but people are really liking that stuff. So the lunches, the vendor lunches are fantastic, and I could rattle off a lot of vendors that have done that. I think Oracle comes to mind. That was one of our vendors. But I know the question was about relationships. The relationships have stayed the same or gotten better. We continue to do additional business, but the discussions with the vendors are slightly modified to include what in your product set can help out with the COVID crisis. And it's a bonus if it's something we're already licensed for. So, some of our vendors, like our telemedicine vendor, for example, we use them, but there's additional features that, we may not have known about that we've started getting some kind of free education on, and that is how to bring other providers into the telemedicine conversation. So that was interesting. Or how do you address the translation problem? Sometimes you get patients that don't speak English. How are you going to do that over a telemedicine call, right? And I know right now there's probably somebody saying, well, how do you do that? And the answer is, I don't know either. I have to ask the team. But they have got it handled. So yeah, that's a good question too about the vendors. And the vendors, I think there is a small part to say about the vendors about availability of technology. So some of our vendors that deal particularly with laptops, cameras, anything related to getting someone to work from home, they're having a difficulty in their supply chain. And we too had difficulties in our own supply chain in the beginning with masks, and masks in particular. Hand sanitizer was good. Supplies to clean the hospital are good, but the mask situation was always a discussion topic. How many do we have? As we sit today, all that's very good. We have greater than a 6-month supply on hand. So I feel like, I'm getting a good message from leadership above me that we're good to go. And I feel good about it myself. I mean, I've ventured down to the supply chain department many times, and, we've got a super large inventory of masks. And the thing about masks too is that even with a super large inventory of masks, if you're not all working on site, then that extends the life of the inventory that you have. So, as this thing keeps going, as people get comfortable working at home, the hospital is evaluating continuing, that work from home or that remote work model to some degree going forward. But supply chain has touch points into like everything, and vendors too.
Absolutely. So I know you kind of touched on the language barrier. Are there any other challenges that you all have not been able to come up with a solution for? And our peers that are on with us today, what could they possibly help you all with?
Well, we haven't ran into an insurmountable problem, just problems that you don't want to deal with that are tough subjects, but we still do the right thing. And probably the most difficult one is, and this is hospital centric, if a family comes with their child to be treated like a surgery or something. Most parents want to be there, but we can only have one of the parents there. So that's very tough. If anybody has children, you want to be there with your kids. And so only one of you can be there. And that's a tough situation when the whole family comes, because it's a big thing, surgery, and especially in the case of spine surgeries, that's big stuff. So that's been a challenge. And now the families, patients and families, I'm not there when they have the conversations. I just hear the reports, but they're going well. Families are understanding, and we're doing it in love and care. So they get it. They know what's going on. So that's probably the biggest challenge. It's mostly interpersonal. COVID has really changed the way we relate to one another, or the way we kind of have to relate to one another. Creates some interesting interpersonal scenarios. And as far as how peers can help, I think probably the most important thing is recognition of the times we're in. I think that means, as a vendor, when you call on customers, at the vendor headquarters, if you will, I'm sure every vendor has you're sitting around a table or on a conference call, and you're talking about sales and upcoming things, and just recognize that now is probably not the best time to be pushing, salesy kinds of things. It's mostly about, let's take care of our healthcare workers that are out there, all of our frontline people, and be asking more, how can we help get back on the feet? Then look for opportunities to generate new sales. Now, I know that has to happen, but I get two forms of vendor calls these days. The first form is the how we can help form, and the second form is the the sales pitch and wanting to get together. These days, during the crisis, I would say most of your technology leaders do not have time to do the calm, have a cup of coffee and talk about the future of IT type conversations. They are trying to maintain operations and really build in an effective remote workforce. So they'll get back to that. We'll get back to doing those kinds of things. So the best way, I think, is just to adopt a mindset of help, and find ways to integrate help into what you're doing at every turn if you can. And just give props wherever you can to the healthcare workers that are out there. I know everybody does that on TV and stuff, but it's a real thing. We had the Blue Angels fly over Scottish Rite and all the area hospitals the other day. That was awesome. So that kind of stuff really goes a long way.
Oh, yeah, it was awesome here in Houston, right in the medical center. It was really, really cool to see that as well. But we are right here at our 45-minute mark. Again, James, we all want to thank you for joining us and providing such valuable insight, as well as everyone that logged on with us today. And a big thank you once again to everyone, and we hope everyone has a wonderful afternoon.